Education Committee, part of the Education Committee for ChildKind International, along with Dr. Bill Zemsky and Meredith Trant, our program director. So we welcome you today to another in our webinar series, and this one is quality improvement in pain assessment and treatment. And we will be joined by two guests that I will introduce in just a moment. And so this webinar will focus on accessing and leveraging QI through EMR systems, steps to a successful QI approach with or without EMR, gathering the right team and institutional support, and challenges and successes in quality improvement, especially as they relate to pediatric pain management. Just one moment, please. So just for those of you who might not know, ChildKind, our mission is dedicated to improving the quality of pediatric pain care around the world. And we also certify and recognize institutions committed to and who excel at pediatric pain management around 5 principles. We also host an open resource library to help any institution in the world improve their pain management. And if you're interested, feel free to visit our website and sign up for our quarterly newsletter. And just so you know, we currently have 17 certified healthcare organizations, and there's 20 more who are in our certification pipeline. And so if you're interested in knowing more about certification, again, visit our website or contact Meredith, and we're happy to set up an introductory call. And we're really excited because today we have over 90 registrants for today's webinar, representing 36 different institutions, some as far away as Australia. So clearly there's great interest in this topic of quality improvement as we all strive to improve our pain management for kids. So just a few housekeeping before we get into the meat of our webinar. If you could please remember to mute during the presentations. The second half of the webinar is really focused on questions from the audience. So what is it that you need to learn? Where is it that you're struggling with pain management? And so feel free to unmute and ask and speak to the group and or put questions in the chat. I'll do my best to monitor those questions. And so the webinar is recorded and available on the ChildKind website if there's colleagues of yours that you think would be interested. So without further ado, I want to introduce our two guests. So Allison Barberio is the Director of Quality in Pediatrics Service Line at Inova Health System. She provides clinical outcome improvement support to their children's hospital, 3 additional regional NICUs, pediatric emergency department, and 2 different sites and ambulatory specialty clinics. So clearly she runs the gamut and can certainly address just about any site that children may, you may find children. And then Dr. Elena Waynick is a pediatric hospitalist at Connecticut Children's. She's an associate professor of pediatrics at the University of Connecticut School of Medicine and the director of clinical effectiveness at Connecticut Children's, and has advanced quality improvement training. She is also the quality and patient safety officer at her home institution, both leading and mentoring others in QI work. So I think we're very lucky to have both of these very experienced and knowledgeable guests here today to not only do short presentation, but also to engage in discussion. And so we have asked them to just give us some highlights of what we need to do over about a 10-minute or so, 15 tops, little presentation, I guess, because we'd really like to engage you all with hopefully finding some insights into your particular problems around QI. So I am going to stop sharing my screen so they can share theirs. Okay.
Paula, would you like me to go first?
Oh, I suppose that's one thing we never did do, Allie. You're on the top of the slide. Why not?
Alrighty. Well, hi everyone. Thank you so much for being here today. I am Allison Barberio. I am the Director of Quality for the Pediatrics Service Line here at Inova Health System. Inova is in Northern Virginia, if you're wondering where the heck that is. And I just want to talk to you today at a very high level around just general quality improvement strategies, kind of starting at the basic level, and then really making it pertaining to pediatric pain and other proxy measures that we use. So I think it's also an important point that I try to make when I talk about quality. I do not have a clinical background, and that's not a requirement to do quality improvement. So I do just want to put in that plug for anyone who may feel kind of out of their depth. I am certainly not a subject matter expert on pediatric pain management, but my job is to facilitate and motivate our teams where their subject matter expertise lies. So my home institution is Inova L.J. Murphy Children's Hospital in Falls Church, Virginia, just outside of DC. We're a 226-bed children's hospital within a very large adult hospital. So on campus, we have about 1,000 beds. And we use Epic as our EMR, everyone's favorite question to ask. And we're a level 1 adult and pediatric trauma center. We have an extremely large NICU, level 4 NICU. And we also have other specialty services like a PICU, PCICU, HEMONC services. So very important when we're talking about pain and the change management related to pain initiatives in our hospital. We're often dealing with extremely large groups of team members that we're educating and trying to change behaviors. So this is a very 30,000 level view of how we approach quality improvement at Inova. There are certain areas when it comes to quality improvement that you need to be extremely structured, which can feel overwhelming. And there are certain areas where you just try it out and see if it works. And it's a little bit less structured. So for our process that works very well for our teams is we start with what we call the discovery and triage. So that is when someone has a hunch that, hey, I feel like we're not doing so great at this, or maybe we could do this better. We try to just find some baseline data to say, is that true? Is that maybe just one person's perception? And truly starting there. Then we start to establish a high level case for change. So that often means going to either the local or operational leader of where you're wanting to see this change occur. That could be a director of nursing, that could be, the EVS manager, if that's related to that. So really going to the local leader and saying, hey, we identified this. Do we have your support in investigating it further? Because you're really going to need them once you start to implement change. Then a very important point for any project is defining your scope. We, working in healthcare, want to solve the world's problems. And sometimes when you start a project out and you don't clearly define exactly what you're trying to do, you just kind of end up spinning your wheels. And it can be exhausting mentally, physically, in every sense of the word. So truly looking at, this is our aim and our scope of what we're trying to address. And then obviously identifying your key team members. I always say that when you start your working group, start small. I would say less than 10 members. And then as you get to different areas of your project that you feel like you need certain stakeholders' input, include them at that point. It's very daunting when you come to a meeting and you're trying to coordinate 60 different people. That also means that they're going to miss every other meeting and they're never going to be caught up on what you're working on. So start with a small, consistent group and build as you go along and identify different areas. So the next piece is diagnosing the problem. Process map it out. Get out there and walk the process. See what's going on. Next, you want to start, once you've mapped out your process, thinking about what are some possible solutions. Those can be very hard to do solutions. Those can be very easy to do solutions, and really prioritizing your solutions based on how much effort they are and how much benefit you're going to get out of them. So once you test out your solutions and you decide, hey, this is really going to work for us, then you have to start spreading the change. So this is extremely hard to do, mainly because you might have one team, one unit that is extremely invested in your change and they want to see it happen. And then you have another unit that says, I don't think we have a problem with this, or I don't think we're going to do this. And it's not that they have ill will, it just means that maybe they weren't involved enough in the beginning. Maybe they don't understand the why behind what you're asking them to do. So that this time right here, this spread the change, it's continuous because you're always going to have new team members and new providers coming on board. So you're going to have to continuously work and make sure that they understand what the change is. And then lastly is your maintain phase, which is basically, do you have a way to keep tabs on this so that you're not working on the same project in 5 years, which I think has happened to all of us, unfortunately, at some point. So for me, this is something that's extremely important as your quality lead, that we decide how we're going to keep tabs on this. So as far as identifying your data, I'll speak from personal experience that getting information out of Epic is not that easy. It can be very challenging. And that's not necessarily the fault of Epic, it's just an extremely complex product. So when we were looking at our pain numbers, we did a couple different things. We looked at where can we start to just do spot checks. So on our nurse manager dashboards, you can look down the census of a unit and you can see in one fell swoop how many of those patients have overdue pain assessments. So I partnered with several members of our team and we said, hey, a couple weeks a month at random times, we try to avoid the morning time because we know that's when med passes are happening and charting might be a little bit delayed, but we might say, hey, let's just look down the census list and out of how many patients needed pain reassessments, how many of them were overdue. So that just gave us a very simple spot analysis. It didn't require any kind of reporting. And then we actually gave that information back to the teams. After doing that for a couple of weeks, it was pretty easy to pick up on trends, which units were like constantly in the high 90% and which units really needed some additional support in order to achieve what we wanted them to achieve. Another area that I think is really helpful, especially me as a non-clinical person, is observation. Put on scrubs, go hang out on the unit, talk to the team, ask them very transparently, what's going on related to this? What are your concerns? What are things that you think we're doing really well? And 9 times out of 10, they're going to share with you very transparently. So that's truly where I think observation comes in. And then lastly, like I said, feedback. So feedback not only from our team members and feedback from our EMR, which is what we've documented, but actually feedback from our patients and their families. So in our institution, our nurse leaders they try to round on each family every day. And they ask questions related to like, how's your experience? All of those kinds of things. But they also ask, do you feel like we're managing your pain to your expectations? And so that was a data source for us that had nothing to do with the EMR. That is, really great data that we were able to get from that rounding tool. So when we think about pain management, we get a little bit tied up in thinking about the pain scores. We have to keep the pain score below 8. If it goes above 8, we've failed. Well, in reality, there are a lot of different ways where we can think about pain, also in terms of discomfort. So for example, in our NICU, we looked very closely at parents' perception of us managing babies' discomfort. It's actually a question on the ChildKind survey. So that was something that we used from that aspect. In an ambulatory setting, we actually looked at for our HEMONC patients, Are we adequately controlling their chemotherapy, nausea, vomiting? Obviously, they are going to be miserable and very uncomfortable if we are not controlling that aspect of their care very well. So we implemented a project related to the PNAT score, and if we can assess and intervene more quickly when a patient reports chemotherapy-induced nausea, vomiting, and we were truly able to bring that back to the team and increase the percentage of patients who reported complete control, which is truly our goal. So lastly, in terms of lessons learned, when you come to that first meeting with your stakeholders, try to have some simple baseline data. So that way you have something to talk about and you're not talking about people's perceptions. You're truly talking about, this is what we found in our spot checks over the last week or two. It's not in a punitive way. It's just saying, hey, this is how we realize that this is worth working on. Consider untraditional data sources. So talk to your regulatory team, your patient experience team. They may have existing reporting that is either required. So I know that pain reassessment is a required measure to report to Joint Commission when they come and visit us every few years. So there probably is an existing report within your EMR. So I would highly recommend talking to them, and then you can leverage it. One thing I consistently need to tell myself, progress, not perfection. We get very particular about things when we work in quality improvement, mainly because we're a bunch of type A people. But start with the simple wins. Oftentimes when you're working on a project, you identify the big scary monster in the room. I don't recommend tackling that first because it will feel extraordinarily difficult. Build up to it. Along those lines, establish what's within your control, your influence, and your concern. So within your control means you have the power to change it. This team of stakeholders has the power to change it. There are things that you can influence, but you don't necessarily have the direct power to change. So for example, staffing, things along those lines. And then think about what concerns you. So what impacts the problem, but probably is not going to be able to be fixed. So an example of this is like, we really need to build a hybrid OR. Okay, yes, that definitely concerns our problem, but no one within this group has the ability to whip a hybrid OR out of their back pocket. So that we're not going to put that on our list of immediate solutions. And then one of the lessons I think we've all learned throughout this pandemic is it's always going to be a challenge to maintain your project as a priority, especially when you don't set definitive timelines. It can kind of linger on. So don't be afraid to make a conscious pause. So if your team doesn't seem engaged or you feel like you're having, challenges keeping people engaged, make a conscious pause and say, we'll come back to this when we feel like we're ready as a team to move on this together. So that's just my perspective from how we approach quality at my institution. I'm very interested to hear about your institutions and also, what's going on in Connecticut Children's.
Great. Thank you so much, Allie. And what I think we'll do is we'll keep going and we'll get Dr. Wainick to present, and then we'll open it up to the floor. And what I encourage people to do, I'm having some technical difficulties. I'll just turn my camera off. What I encourage people to do is sometimes you have great questions and you're dying to ask them, but if you could hold them, but one way to make sure that you don't forget them is feel free to pop them in the chat as well. Okay, so I'm gonna bring it, pass it over to Dr. Wainick, and okay, I'll turn my mic off and she'll turn hers on.
Okay, hi everybody. My name is Ilana Wainick. I'm the Director of Clinical Effectiveness at Connecticut Children's. It's exciting to be here with so many people, and I feel the need I was peeking to see if I knew anybody. So hi, Renee Manwarren. Haven't seen you in many years. We used to work together. I think that I'm glad that you went first because, Allie, because I think that what I'm going to do is a really nice complement to what you explained. So I'm going to tell a quality story. And I'm going to talk about some of these concepts that Allie already brought up. So in my line of work as the director of clinical effectiveness, I develop and I implement clinical pathways, and I do a lot of quality improvement work related to improving our care of patients, specifically on these clinical pathways. How can we make care better? How can we get better adherence to these clinical pathways? And so this is one of our stories, and this is how we went about doing a quality improvement project, which is still ongoing, to improve adherence to this to this clinical pathway. So I'm just leaving this up here. I'm not gonna, you guys hopefully have read it. I'm not gonna harp on it because I know I'm preaching to the choir here, but I think we all know that venous access pain, either for lab draws or for placing IVs, is the most common painful procedure that we do in a hospital setting. And it's really important to control pain for all of the reasons that you see up here. So here's the story. So what you're looking at here are two control charts. I'm going to have you peek at the one, first of all, to the left. So for those who are not familiar with control charts or run charts, on the x-axis is time. So I know you can't read that because there's like 5 million weeks worth of data, but each of those, what's written there is a week in time. And then whatever metric that you're following, that is on the y-axis. So in this case, the y-axis is we are looking at the proportion or percentage of IVs placed for which topical anesthetics were used. And the scope of this was just on the medical surgical floors. So this was not in the ED ambulatory areas, PICU. So this was just on the medical surgical floors. This is where we decided to start this work. You do not need to read all those yellow boxes on the left part of that graph, but just know that during the 1.0 version of this project to increase use of topical anesthetics, we did a lot of different interventions and we more than doubled our rate of topical anesthetic use. So we started out at like only 11% of IVs we were using topical anesthetics for, and we got it up to just about 50%. Our goal, by the way, was never 100% because we have a lot of teenagers who just don't want us to use topical, they're offered, but they don't want to use topical anesthetics. And then I'm going to tell the rest of those, what the rest of those failures are later. So we did all this really, really great work. And then you can see 3/20/20 is when the pandemic started. And really soon after the pandemic started, our rates of topical anesthetic use for IV placement just tanked big time. Plug here for following data, because we would have never ever known that this happened if we weren't following data. But so this is the story, and I'm going to tell you about this QI project 2.0. So after the pandemic, and then just to make the story complete, if you can just look at the chart on the right, that is just looking at IVs placed in the children who are infants, so less than 1 year of age. And you can see that we really almost never use topical anesthetic to put IVs in babies, and that's clearly a problem. Okay, so our new baseline, so you talked a lot about the importance of getting data, Allie, and so our new baseline for the start of this project 2.0 is that only 24% of patients admitted to our med-surg floors were having topical anesthetics used prior to IV placement, which again is the most common painful procedure done in the hospital. Okay, so this is another way of looking at a quality improvement problem from what Allie talked about. And this is I like this because it ties a whole bunch of different things together. So for those of you who aren't familiar, this is one way to visualize something called the sustainability model. So ideally, when you are performing quality improvement, you do a bunch of different interventions and you hope that 1 or 2 or 3 of them actually makes a difference and moves the needle on whatever the improvement is that you want to make. And But then you need to make sure that those improvements are sustained, which I know Ali talked about too. So I'm just what I really like about the sustainability model is it ties together the purpose of your project with the climate and culture of where you work or where this project is taking place. And it makes you also think about the relationships and the environment where these behaviors are taking place. And that's really, really, really important to think about all of those things. And then in the blue boxes, what you see are sort of the different things that you need to think about in order to make these projects happen. So again, the purpose of our project was to prevent unnecessary pain experiences in pediatric patients, specifically looking at venous access procedures. And I'm going to start with the principles because this is, I think, a good place to start. So the principles that we had in mind, and there are some buzzwords in here and they sound kind of cringy, but I'm going to explain what these mean. So we wanted to create value for the customer, and the obvious customer here, right, are the patients and families. We wanted to make their pain experiences better in the hospital. But also thinking about our team members as the customers. So in our hospital, the nurses are the ones who place most of the IVs. And we had a lot of systems in place that were not very respectful of the nurses' workflow. So the nurses really are our customer as well. We needed to create a constancy of purpose, right? So for me, because I'm passionate about pain prevention, I felt like I had the purpose here, right? I was going to make sure all my patients had an order for topical anesthetic, but we needed all of our staff to feel that same constancy of purpose, that we are always thinking about managing our patients' pain. Respect for people, it's similar to creating value to the customer. We need to respect our patients and families doing the right things. And again, we needed to respect our team members' time as well. We all needed to take a stance of learning continuously. That's what quality improvement is, right? It's not a one and done, or I should say it's very rarely a one and done solution, but we all need to commit to going through all of this together and learning continuously to continually improve and monitor whatever it is that we're focusing on. We needed to focus on process, and this played a huge role in this particular project, so I'll talk more about that. And then you need to understand and manage your variation. So I showed you the data before, and you need to understand how to visualize your data to understand if what you're seeing is just a bad week or a bad day, and we don't react just to that. You really have to understand how to look at your data in a way that allows you to understand patterns and significant patterns and what is significant change. So the results are also important to think about ahead of time. What are you trying to achieve with your quality improvement project, right? And Ali talked about this, right? You really need to define the problem. Usually the defining the problem happens when you do direct observation, but also look at data. That's how you define your problem. You want to define the objectives and your scope, like you mentioned. And in this case, we decided to focus on only the med-surg floors to begin. Well, that was twofold. I think most of our IVs are placed on the inpatient, or many of our patients have IVs on the inpatient services, and certainly we do a ton of lab work on the inpatient services. I'm a hospitalist and the director of clinical effectiveness. That was an area of my influence, so it seemed like the right place to start here. And you have to define your team members. And again, I agree, like key team members. But the other thing I want to mention is do not meeting to death, huddle. Huddle, don't meet. And I think maybe, Ali, this is part of what you were talking about. Sometimes you need to have bigger meetings to help define your goals, etc. But as the project goes on, you can do 10-minute huddles, 15-minute huddles. They don't need to be these big drawn out meetings. And so I highly encourage that. And really define what is it that you're going to do. So going back to the results box here. So we picked some process measures, right? Because we were trying to improve our process of making sure that when placing IVs or doing labs that we are using topical anesthetics. And so the logical process measure to follow was this percentage of IVs with topical anesthetic use. We also wanted to specifically look at topical anesthetic use in infants because we had identified that as an extra special problem. And then also decrease the patient refusal rate. I didn't show you that graph, but just shockingly, as soon as the pandemic started, we think this had to do with nurse turnover and a high level of burnout. Our rates of refusal of topical anesthetics skyrocketed. And we think we had all this new staff that wasn't trained in how to have these conversations with families. And then finally, if you are able to, for whatever your problem is that you're trying to solve, pick some outcome measures. So for us, it was improved pain control, and also just in speaking with our team members, because I told you they're an important customer here, is the process more efficient and reliable, right? We didn't want to create more work for them. We wanted to make this easier for them to do the right thing. So what is the climate and culture? What do I mean by that? So the climate and culture here, what we wanted to see is that healthcare providers at our institution felt like they have the responsibility to help prevent unnecessary pain. We want that to always be what's on the, what is thought of with any procedure in the hospital. And then you hear a lot in the QI world that there are a lot of tools in the quality improvement world, but the tools cannot own you. The tools are for you to use to help you enact your improvement plan. So for this particular project, we did a number of different interventions, and I'm going to talk about those on a separate slide. But the idea is that the tools that you use, whatever you pick, they interact with your systems. And our systems for our project were the system of the nurses putting in IVs. And then finally, thinking about the relationships and the environment. So, what key behaviors do you want to see in your team members who are doing the right thing? And we actually measured the key behaviors by direct observation, and we kept track of those on an abnormality tracker. So we did some random, we had, secret people on the floor monitoring these conversations with families and doing some direct observations as well. Okay. Oh, I put that there. I don't know why I had that. So these are our systems. We had our venous access work system. We had our quality improvement systems. And then finally, our communication system. So we really didn't want to downplay how important these conversations that team members are having with families, because that's a huge part of it. Because I showed you that our refusal rate went up, which clearly it seemed like it stemmed from communication. So I'm going to just briefly go through some of the strategies and interventions that we implemented so far during this project. So in the version 1.0, we had implemented a clinical pathway. You can implement a policy, a guideline, whatever your institution has. That's why I kept it vague here. That was really helpful during the 1.0 project, and it helped us a lot with our continued education of staff members throughout this 2.0 project. So, we talk a lot in quality improvement about levels of reliability of your interventions, because some interventions have low reliability, but are necessary. And what I mean by that, I'll give you an example. So education, right? We have to educate our team members about how important it is to use topical anesthetics, right? But just because and that's necessary because our team members need to understand how to use them, what they're for, et cetera. And that is necessary. But just because I educate someone to do something doesn't mean they're going to do it, right? We're humans, we're fallible. So that's a low reliability intervention. But other interventions, like things you do with your electronic health record, or really creating a new system where something is always done, are higher reliability. So it's keeping that in mind as you think about your interventions is also important. In addition to what Ali already mentioned about thinking about like bang for your buck, right? Of, how many resources will it take to do an intervention, and is it worth it? Or maybe there's like a really low-lying fruit, easy intervention that you think will touch a lot of patients, people, et cetera. But also think about level of reliability, because you're more likely to get sustainability if you have a high level of reliability of your intervention. So anyhow, what we did was we took our education one step further and just educating staff. We tried to formalize the education of topical anesthetics for venous access procedures. We placed it into all our new higher education, annual validations, et cetera, so that there would be continual exposure of our new team members and ongoing team members to this important work. We created order panels in our EMR. We also have Epic, but you can create order panels or order sets in many EMRs. And what we did though was kind of cool. I did not do this. I have no epic knowledge, but this wonderful nurse practitioner who I work with created this order panel that was able to screen by age, because certain topical anesthetics are inappropriate for certain ages. And so only the right topical anesthetic agents would show up with, and they were pre-checked on order sets, on admission order sets. We deployed some required EHR documentation for the nurses, because if you have to document it, it makes you think about it more and more, but selfishly, it also helped us with data collection. So we can monitor the state of the situation. And then we worked a lot with our child life staff on non-pharmacologic interventions, including they provided wonderful scripting for our for our nurses to be able to talk with patients, but also parents about the different topical anesthetics that we have. We developed quality metrics to monitor performance, and I've shown you some of those. And then finally, what's really, really what's important about the metrics is not that you just follow them, but that you make it a point to share the metrics with your frontline staff who's doing the work. It makes them feel involved, you get better buy-in, and it's critical that you provide a mechanism for feedback and discussion with the people doing the work on the front line about this, because some of the best solutions come from your frontline team members. At our institution, this was one of our interventions that was super helpful. We put the weekly metrics up on the DMS, the daily management system boards on each of our med-surg floors. Huddles happen twice daily for morning, once for the day shift, once for the night shift, every single day on our med-surg floors. And they talk about this data as part of their DMS huddles. Figure out some system for reviewing your failures. And I'm calling failures might turn out not to be failures. And I can talk about that in a moment. But for us, the failures were, we didn't use topical anesthetic, right? So what happened with this in this instance? And our nurse leaders, our nurse managers and assistant managers committed to going through the failures every week on their floors and trying to come up with patterns. They gave some individual nurse feedback, which made a huge difference. So we were really we weren't just following data to follow data, we were really using our data to help drive improvement. You can think about visual management or job aids, and that's sort of like a vague bucket term for anything that is in somebody's face, reminding them to do the right thing. So having our chart up on the daily management system boards is a visual reminder. We had laminated information about the individual topical anesthetics on our IV cards. We also had that scripting on our IV cards for the nurses to have handy before walking into a patient room. So those are examples of visual management systems. Use your influencers. There's a great book in quality improvement just about influencers. It's a whole book. So you guys know who the influencers are, right? Like they're going to be, in my case, the nurses on the floor who, if somebody can't get an IV, that's like the first person they go to because they're the best at putting in IVs. You got to get those people on board, because if they're like, I don't believe in topical anesthetics, that's not how I put in an IV, and they're the best at putting in IVs, like game over, right? You have to get the influencers on board right away. And then these last two, I think, are so critical and so important. I think we do a lot of trying to make people do better at what we are already doing. You know, you just want to say, just do it better. Why aren't you doing what you know you're supposed to do? And sometimes you have to be really brave and completely redesign your process altogether. And that's a hard thing to do. And this is what we did and what led us to have some success in a way that I think we didn't have during the 1.0 project. So we, at our institution, the providers like myself, the doctors, the advanced practitioners are the ones who place the orders for the topical anesthetics. And another big root cause that we uncovered when trying to figure out why we were not having great success at use of topical anesthetics was that it was a real pain in the butt for the nurses, just to be frank, because they would go into the chart, and if there wasn't a topical anesthetic order, they then would have to go find one of the residents or a provider to place the order, and then they would have to go back to the Omni, like the locked things that you have on your floors, to get the topical anesthetic, and then go back to the patient room and then put on the LMX, which takes 30 minutes to wait for, when they have 5 other patients to take care of. And it was just too many steps. And they just frankly didn't have the time. And sometimes there were these competing priorities of another really sick kid or an antibiotic to hang, et cetera. And so we did a couple things. This took us a really long time to figure out, and a lot of talking to risk management for the whole hospital. We now keep our topical anesthetics in the locked IV carts. We also introduced the J-tip mechanism, right? The CO2 jet, because you don't have to, there's no wait time with that to introduce lidocaine. But we keep all this stuff in the IV carts. So it's not running back and forth. Everything is right there. And that made a huge difference. We piloted, just to talk about how you discussed, Allie, start small, right? Just don't implement something everywhere in the hospital at once. We piloted the IV cart solution on one floor. And we did that, and we had weekly huddles about how that was going. And when it started to go really well and we tweaked it and got it just where we wanted it, we spread change to the other floors, and it went really, really well. And then the other thing that we talked about, and that's actually been approved by all the committees we're just doing the EPIC build for, is we are going to have a nursing treatment protocol for the ordering of topical anesthetics, so that if there's not an order, the nurses can do this. It's pretty prescriptive how to do it and safe. And so we were able to do that as well. And then the last thing, which is so critical, you have to get support from hospital leadership. During the 1.0 version of our project, we didn't have strong support from our nursing leadership, and the project just it felt like fighting, an uphill battle, like pushing the boulder uphill all the time. This time we had amazing support from our nursing leaders. And actually this is the metric that the med-surg nurses have chosen for their metric, their thing to work on for the year 2024. So it's very, very exciting. This has really changed. So this is what our chart looks like now. So that you can see where the pandemic begins, and you can see we've started to shift our median up again, and we're going to go live with our nursing treatment protocol, and I promise you that will go up even more. Now, this looks like maybe sad that we still are below 50%, but something that we've learned in our continual review of data is that the majority of the failures are these teenage patients who come in frequently with their chronic diseases who just don't want topical anesthetics, right? And so that's okay. And now that we are sure that some of those refusals that I had shown you went up are no longer just because of poor communication. We know this because of our direct observations, et cetera. We are going to change our metric to exclude the refusals now, because we can feel really good that we're not inappropriately excluding the refusals anymore. And then the other group of patients who are not routinely, there are 2 other groups of patients not routinely getting topical anesthetics. The infants, we need to focus on the infants. And then some of our patients go down to our sedation suite for procedures. And for some reason, they're not using topicals down in that area. So we need to spread change to that area. So it's going to get better. It already is getting better. And I, believe it or not, feel more hopeful about the sustainability of what we're doing than what we did the first time. So, I think for me, as one of the quality improvement leaders in my institution who does a lot of coaching and mentoring, I learned a lot. I've been learning a lot. I continue to learn a lot from this project, which I thought maybe was worth sharing here. So coaching or leading a process that you don't personally own can be challenging, but I promise you it can be done. And in considering this principle, I told you these principles are really important. So when thinking about the principle of respect for persons, my role really evolved from the leader of the project to just the coach to help the nurses lead the change. And boy, did they step up and have amazing ideas. And I really am just there to help give structure and support to the project. So similar to what Allie was saying, right? Like Allie's not a physician. I am a physician, but again, you don't want me putting in your IV. You just don't. You want the nurses doing it. It's not my process. Leadership sponsorship, like I mentioned, is key to creating that constancy of purpose and helps you propel things forward. Please evolve your systems. Don't get stuck in just trying to do better of what you're already doing, which is not working. Alignment is critical and helps really create or change culture, and that can be really, really hard to achieve. Teaching others about continual improvement or quality improvement can be difficult. It's not a concept that everybody's familiar with. And I think taking a moment to get people to understand that you're just trying to continually improve and not necessarily go for perfection, like you were mentioning too, Allie, but just teaching this concept that this is something that we need to work on together and continually reevaluate is important. And then personally, at our institution of Connecticut Children's, there's room for improvement in the quality improvement culture with respect to widespread awareness of performing QI in healthcare settings. People are afraid. I told you we had to get risk management involved, and somebody was worried about Joint Commission. And Joint Commission, if they know that you are doing quality improvement, and that's why you're doing X, Y, and Z, they understand. They actually do understand that, and they will respect that, which I learned. I didn't know that. But we at our institution now have an internal quality improvement course, and so the culture, I think, is changing at our institution, which is very, very exciting. That is all that I wanted to talk about with this group, just to tell a story and give insight into how we do things and how you can do things. I have coached a lot of smaller hospitals and hospitals that are small community hospitals that just have a floor of pediatrics. And you can do all of this wherever you are.
Okay, well, thank you. I'm going to open it up to the floor, but we already have some questions. So, couple of these are, Ilana, if you could see, is the use of topical anesthesia tied to the IV placement through general documented in the flow sheet with analgesia use documented in the MAR?
Sorry, I'm just trying to understand this.
Yeah. I don't know, Deb, if you want to put
what is the LDA? Is that like the Waldos, like where the nurses?
No, I asked that, and it's lines, drains, and airways, but everyone calls it LDA in Epic.
It is. That is the you have to know how your institution works. We actually pull it from two places. We pull it from the MAR and the LDA. We pull it from both so that we don't miss it. And I should say that our goal is to improve topical anesthetic use for any venous access procedure, but because our nurses don't have to document lab draws, we're using IV placement as our surrogate metric for all of it.
So can I just clarify the question? So when you're pulling your data, when your nurses document their LDA or they insert the line, at the time that they insert the line, are they documenting their analgesia use as well?
Yeah, or they are, because we have a little drop down menu that allows them to select multiple, I think it says it has sucrose, it has LMX, it has the J-tip lidocaine, it has patient refused, it has all of those as options.
Okay, that's great. Thank you.
And one of the other, Katie Brooks book out asks, what were your topical anesthetics? So I think you just LMX.
Yeah, I can give you a whole talk about the literature behind this, but we promote use of LMX or the J-tip lidocaine as the top choices because we know that they provide the best analgesia of anything out there. We encourage the co-use of sucrose for appropriately aged babies, comfort positioning, obviously for everybody, some of the other non-pharmacologic things, and really the sprays, the cold sprays that we have, Those are like our last line topical anesthetic
Mhm.
medication that we promote because people don't really use them correctly. You know, there's a lot, like to use it correctly, as you guys probably know, you have to spray it on literally directly before you put in the IV. And we have just found from observations that it's often not used right. And we know from the literature that it's not as effective.
Mhm. Great. There's a couple, oh wow, there's lots of, you guys are generating discussion. So someone else was asking, how's your IV cart defined since there's a medication in the cart? Would you share the logistics of the cart and the process for quality sustainability standards? And I think that's probably all that work with risk management you had to do.
Yeah, I mean, honestly, our IV carts are like, they look like the carts that you probably have for like emergencies in the hospital where you keep all your emergency, you know, your epi, your intubation equipment. There's multiple drawers in the cart, and all of the IV supplies, you know, the tubing and the needles, et cetera, are kept in that cart. And we, our nurses have a process, like we had to create this to make it safe, where weekly someone does inventory of the cart and takes whatever is needed out from the Omni and puts it in the cart, but the carts all are locked and have codes to get into them.
Great. Renee, you're here, so maybe do you want to just turn on your mic and ask your question?
Sure. So what I asked was, how have you leveraged external influences, sirs? And I couldn't help but be reminded, because I see Stephen Weissman's face, that I was in a competing hospital back in the 90s, and his hospital had a billboard not far from ours about how they use topical anesthetics for all needle procedures. And so within the month of that billboard going up, we use topical anesthetics for all needle procedures. And then Steve and I would contact each other periodically to see how many tubes of EMLA they were using versus how many tubes of EMLA we were using. And thank goodness we don't email each other about tubes of EMLA anymore, but wondered if you had used external sources. Yeah, I know you talked a little bit about the patients, but how do you leverage those?
Yeah, I love that question. And I think, so we did. So I think that you can talk about this is like motivation, right? Like, how do you motivate your team members? And I think a healthy level of competition is, we know that is a known quality improvement method that works, is using healthy competition. There's different ways to do that. You can compare yourself to another institution. And for us, Connecticut Children's used to be leaders in exactly this area, and then we stopped, right? So we could compare ourselves to ourselves. There are published studies of topical anesthetic use at other institutions, and we definitely pulled all that literature and used that in a lot of our education. And in addition to using those external motivators, you can use internal comparisons. And I didn't show you guys this slide, but I'm just going to show it because I had a feeling someone might ask something like this, so I had this at the ready. Can you guys see this right here? Did I do it right? Wrong?
Dr. Wainick, we just see your desktop.
Oh, oops, I did the wrong thing. Hold on.
Lovely children.
I messed
Okay,
up.
they're very cute.
That's a very old picture. Okay, you should be able to see this now. Yes. No.
Yeah, we see a lot of, yeah.
Can you see? It's a run chart. You guys see it?
Yeah.
Okay.
Yes, we do.
So this is what I don't know why the formatting's not great on this, but this is what we put up on the those DMS boards on all the units, the inpatient units. And you can see on the right here, this is from a while ago, but this is just an example. We put in the overall numbers, but then we also separated it by the different, we have 3 med-surg floors. And so the med-surg floors kind of had this healthy competition against each other about who is doing the best. And I think that is really helpful. I helped lead this great, again, I'm a pediatric hospitalist, I'm not a surgeon, but we were trying to improve the antimicrobial usage for patients with appendicitis. And there was this one provider who just would not stop inappropriately using broad spectrum antibiotics for long periods of time when it wasn't necessary. And in a very friendly way, he was sort of publicly shamed by the surgeon who was leading this project, but they were comparing everybody against each other, against the group. So everybody would get their own little graph that compared their own metric to that of the group. And so those sorts of comparisons really, really help point out, abnormal behaviors.
Well, and I think I'm noticing the time. We have a few more minutes, so I'm going to just do some picking through here. And Dr. Fiona Campbell she says, thanks for a great talk, and sorry that she's going to have to go. But are you if she missed this question or this comment, are any of you partnering with parents to inform your QI projects? So you talk about having a hunch. I don't know what's wrong with my camera. I'm going to turn that off. You talked about, Allie talked about, having a hunch. Who does the hunch come from? And are any of them ever partnered with parents to be able to do that outside of your parent experience surveys?
Yeah, absolutely. So, in terms of our families being influencers, depending on obviously their child's diagnosis, they may have a lot of experience with interactions in different healthcare systems. And they're very much bringing forward, like, this is a practice that we saw elsewhere. This is truly what we would like to see for our child, or something along those lines. So, that really is how the conversation starts, and then it flows forward from there. We also have team members consistently coming in from other institutions who bring their great practices with them when they join our team. So that's another great source. As far as having families, members of our team, yes, we always strive for that. I will say personally that I think that we could do a little bit better at making sure that they're included, because I think a lot of times we make excuses for why we don't have a family member present. Like, oh, they're working, they can't make it to, office hours, meetings, or whatever it might be. But I think it is absolutely essential. At the very minimum, when you start to design your solutions, you should run those by a patient or family member to vet them before you even try it out. That was a great question. Thank you.
That answer your question, Fiona?
Yes, and I would say even beyond that, we generally, certainly in Toronto, we need quality and risk management approval for these projects. It's a little easier than REB approval for research, but we have patient partners as part of the team that submits the application, that creates the project, brainstorms solutions, writes up the publication. So they partner with us every step of the way, and it has been so gratifying and such incredible contributions. So I just really wanted to put a plug for that, and I'm glad to hear that you're engaging them in at least some way. So thank you very much for your responses and for great presentations today.
Thanks, Fiona.
And most hospitals will have a patient advisory committee, and so that's a great place to start.
Yeah, I think that, and I think, as we embrace patient engagement more, they are the people who we are here to serve and to help. It only makes sense that we include them in all parts of our decision making. I don't know if there's any other questions that I've missed. I think
I'm just putting this up there for the people who asked what behavior.
right.
These were our K cards, so you guys can look.
I think some of my take homes are certainly sharing metrics and feedback. I do have a question. I think the idea of huddles versus meetings to death, I'm going to use that phrase because I think we need to do that more and more. And death by meeting. And so I have a question about after your implementation and sustainability. When it comes to pain, it doesn't have to pain for both of them quality work. You're doing for people who are here about ChildKind, if they're you know, you have, say, your quality improvement on needle pokes, but pain management is includes other aspects of that of practice. How do you keep momentum so that you have the time and energy to go to another pain, maybe another pain quality, but also continue to sustain some measurement of your new project? Like, so how do you balance improvement, other improvement projects with the ones you're doing? I guess is my question. Either Ali or Elena.
You can go ahead, Ali, first.
Okay, yeah, no, that is a really good question. Bandwidth is always a challenge for each of us. You know, we wear a lot of different hats. And for us, for me personally, there are many projects that are brought forward. And sometimes you have to say, I don't think that we have the bandwidth to do this right now, because we're going to compromise other things that we have going on. And it doesn't mean never, it means we can't right now. And for us, we have as an organization key performance indicators, you know, whatever your organization calls them. But essentially, if we can tie a project to a key performance indicator, it is much more likely to be sustained from a resource and leadership support effort versus if it's kind of an off-the-wall niche project that somebody is doing, you know, for their own specific purposes. So I would say look at your key performance indicators for your organization, see if there's a way that you can tie it to that. And then, you know, sometimes the answer is we need to wait on this. It's really hard to say no sometimes, but that's my perspective.
Yeah, I mean, and again, you really need to have institutional support to have any impact at all. And so, you know, hospitals generally have like their big overarching plan. People call it many different things, but if you can tie it back to that in some way, shape, or form, that can be really powerful. Yeah, and just figure out what are the priorities of the institution and try and align those with that. And you, or if it's something you know isn't an institutional priority, but it's really important, you just have to start advocating and making a lot of noise sometimes.
That's great. And I think you both have touched into organizational support, which is a key pillar of ChildKind principles as well, is that you have leadership and organizational support, because we do understand that the importance at top level that we can give the best in various areas.
Yeah, and just like
so on that note, I know we're over time. No, go ahead.
No, I just was going to say, I think, you know, just really focus on the starting small and then spread change thing, because if you are able to focus small and be really successful, do not underestimate, even in a big institution, like the scuttlebutt. Word gets out. I can't tell, like our nursing treatment protocol, we're just going live right now in the inpatient areas. And I have gotten so many communications for people being like, when can we go live with that in our clinic? And it's huge. So starting small and then spreading change works.
Great. Yeah, it's kind of at that little competition. I want to do that. And you gave us both. I love the way it worked out, high level and then a story to really bring it all together. We so appreciate your time. We appreciate everyone's time today, and clearly a very important topic for many. So Meredith will be able
Sounds like
to post means if there's a topic. What was that?
Oh, you are breaking up a bit for me, Paula. I don't know if it's the same for others. So I'll just dovetail off of what you were saying, that yes, we have this recording and we will be putting this on our website, and stay tuned for future webinars. I don't know if there's anything else, Paula, you were going to say, but I just thought I would say thank you to everyone for participating today, and especially thank you to Ali and Ilana so much for your time today.
You wrapped it up nicely, Meredith. I seem to be having some internet problems, so thank you all for joining us.
Yeah, thank you. Have a great day.
Now my camera doesn't work at all.
It's funny, I could hear you and it was working, but it would kind of just sometimes go in and out.
Oh, well, now it's not even working.
Oh.
Because I've taken myself, I have my built podium, but I'm a black box. Clearly I might need a new camera. Meredith, I noticed